RetinaRounds, episode number 14, TRD repair in 10 steps. In today's episode, guest surgeon Dr. David Perez Gonzalez demonstrates the 10 steps for successful surgical management of diabetic tractional retinal detachment. Now, it's important to remember that not all tractional retinal detachment repair follows 10 cookbook-style steps. In fact, what I enjoy about TRD repair is that each case represents its own unique sets of challenges. The 10 steps presented here don't have to follow this particular order, but are general principles that can help guide you in successful TRD repair. So let's go ahead and get started here. The first step in TRD repair is to perform a core vitrectomy. That's true for all surgical cases, starting with a core vitrectomy. Once that core vitrectomy is performed, then Dr. Gonzalez is going to segment the anterior and posterior cortical vitreous 360 degrees. You can see him switching hands here, going with his left hand and segmenting that cortical vitreous, again, 360 degrees all the way around. And there's a number of reasons for doing this. One reason is later on in the case, he's going to be tackling those membranes on the posterior pole, and he doesn't want to be exerting any traction on the vitreous base while doing so. The second is sometimes when this peripheral vitrectomy is being performed, the posterior, or rather peripheral vitreous detachment can be identified, and that can help in identifying the proper plane for dissection. So as that vitrectomy is being conducted, you can see that there's some bleeding here that's just nasal to the optic nerve. And this really brings us to our next step, which is to make sure that hemostasis is achieved, not to delay hemostasis. Diabetic blood is very rich in fibrin and can form very tightly adherent membranes. And so addressing hemostasis is really critical, so that the blood doesn't form additional membranes that can complicate the TRD repair. Here it looks like he's cauterizing the fibrovascular fronds so that later on when he goes to TRD dissection, they don't bleed. Right now he's going to a high magnification non-contact lens, and our next step is to try to find the proper plane to dissect off these membranes on the posterior pole. And so he's starting by first removing any residual vitreous over that membrane, and then using a forceps, he's going to lift that membrane, so create some separation between that fibrovascular membrane and the underlying retina. And here he's using a light pipe to actually make a hole, to make almost like a posterior hyaloidotomy. This can also be achieved using scissors, or once that space has been created, sometimes the cutter can be used as well. Once that plane has been identified, we can go into our next step, which is segmentation. So using the cutter, Dr. Gonzalez is gently elevating up the hyaloid face and segmenting the pegs from each other. So you can see here he's using the cutter going around the peg and releasing any vitreous adhesions all the way around the peg before delaminating it. That's going to be really important to prevent any iatrogenic retinal breaks. So again, he's sort of lifting up the vitreous around that peg before he's actually delaminating it with the cutter. So as he's segmenting, you can see that he's following the surface of the retina. He's not lifting up too much, creating space using the cutter as a hook periodically to lift up the vitreous, but not lifting up too much as he's in that plane. Once he's in the plane and segmenting, he's going to follow the surface of the retina. You can see here as that as the gel is coming up, it's creating a lot of movement around, or a lot of laxity around those pegs, and those can then be easily delaminated. Again, here over closer to the optic nerve, using the cutter to follow the plane, not lifting up too much, just following the plane to segment the peg that's closer to the optic nerve. And then once that's segmented all the way around, he can then delaminate it with the cutter. Now, you can see here he's using the cutter to sort of lift up the hyaloid face. There's quite a bit of fibrovascular membrane that's there, and just gently lifting up, using that cutter as a hook to lift up the vitreous, identifying those pegs, and then using the cutter to segment all the way around before he delaminates. Now, he's encountering a little bit of bleeding here, and I like this technique of addressing the bleeding first and then carrying on with the case. And now that bleeding is under control, he segments around 360 degrees, and he can come back to that peg and delaminate it with the cutter. All right, looking for any other, looks like he's looking for any other areas of vitreous to engage. Here you can see that large fibrovascular membrane has been lifted up, and now you can see here now the PVD has really been lifted up, and you can see the vitreous being elevated all the way up to the vitreous base. And so now our next step is to go ahead and complete the peripheral vitrectomy. So now those membranes have been removed in the posterior segment. All that delamination, segmentation has been completed, and now the peripheral vitreous needs to be trimmed 360 degrees. You can see him going all the way around, and as he's going around, some additional layers of the vitreous that haven't quite come up yet, you can see them getting engaged. Using the fluidics of the cutter can be really helpful here. So, using a slightly lower cut rate can sometimes be helpful to create some turbulence to propagate up the PVD. You don't want to go too low with the cut rate, of course, because you want to minimize the amount of traction, especially as you're starting to move a little bit more into the peripheral vitreous, closer to the vitreous base. But this is coming up very nicely. You can see him coming all the way around here and trimming that vitreous peripherally. All right, so once that's been done, it looks like Dr. Gonzalez is going to go ahead and confirm that the vitreous is up by injecting some triamcinolone. He's refluxing using the cutter, and it looks like he's used some dilute triamcinolone, which I really like. You don't want big clumps of triamcinolone obscuring your view. Just a light dusting of any residual vitreous, and you can see here all of that triamcinolone is gone, and there's no residual vitreous left. And then now our next step is to go ahead and perform panretinal photocoagulation. This is really going to help to decrease the likelihood of reproliferation later on, rebleeding later on. So he's going around now 360 degrees and filling in those areas that haven't already been lasered. You'll notice actually in the periphery that there are some spots of laser already. I like actually doing some degree of PRP before the surgery, in addition to doing anti-VEGF before surgery to decrease the activity of the neovascular membranes, decrease the likelihood of bleeding intraoperatively. PRP is a little bit gentler and can have a sort of a slower effect of regressing NV. Anti-VEGF, on the other hand, is going to be more of a rapid regression, and you do have to be careful because you can get a crunch phenomenon where those neovascular membranes can contract and actually create or exacerbate a TRD. So once that PRP has been done 360, it looks like he's just checking around, making sure that the retinal periphery is normal, that there aren't any peripheral retinal breaks. And now he's going to go ahead and do an air fluid exchange. And I like doing a complete air fluid exchange in all of these, on all of these cases. If there are any small oozing blood vessels with the air in the eye, they're more likely to coagulate and decrease the likelihood of significant postoperative vitreous hemorrhage. And under air, you can see that there's a nice peripheral view, and so he's just adding in some more PRP peripherally. I do think that this is your best opportunity to get in your PRP, especially on the anterior side. So make the most of that opportunity and try to get in as much PRP, especially anteriorly where there's the greatest degree of non-perfusion. And there you go. The air fluid exchange is done, and that's just a really beautiful complete case. So here is just a review of those 10 steps that we just covered. First, you want to perform a core vitrectomy, just as you would with any type of vitrectomy case. And you then want to segment the anterior and posterior cortical vitreous 360 degrees so that any manipulation, any dissection that you're doing in the posterior segment doesn't translate into traction at the vitreous base. Bleeding will arise at multiple times throughout the surgery, and it's important to address it as it arises. That could include using diathermy to diathermize any oozing blood vessels. Tamponade pressure can also be used, although I like to use tamponade pressure sparingly, given that these eyes are already quite ischemic. We don't want to further exacerbate any ischemic damage to the retinal tissue. Once the segmentation of the anterior and posterior cortical vitreous has been done, you want to then get into the right plane before dissecting any membranes. If you're not in the right plane, you'll be wasting a lot of time and expending a lot of effort, and you'll often have to redo that work if you're not dissecting in the right plane. So that can be identified in a variety of ways. In this particular case, the forceps was used to sort of elevate the vitreous over the macula, and that created enough space for the segmentation to follow. Lifting the hyaloid over the optic nerve is usually a very reliable way of making sure that you're in the right plane. However, it does raise the risk of potential bleeding over the optic nerve, which can be in some cases difficult to control. So once you're in the right plane, and by the right plane I mean you should be within the or between the cortical vitreous and the retina. Segmentation can then follow, and so that involves using the cutter following the plane itself, not lifting up too much on the vitreous because you don't want to exert traction in those pegs, the trunks where the neovascular fronds are emanating from the retina. But you want to just follow the course of the retina and follow that plane so that you can isolate the pegs before delaminating. And that takes us to our next step, which is once the segmentation has been done, you really want to make sure that you've segmented the vitreous thoroughly all around the pegs before delaminating, which will help to decrease the risk of iatrogenic breaks, especially when using the cutter to delaminate the pegs. And finally, you want to finish the peripheral vitrectomy, identify any residual vitreous with dilute triamcinolone, and staining with triamcinolone is really important in these cases because diabetic vitreous tends to be schitic. There could be multiple layers, and while you might think that you're in the right plane or that all the cortical vitreous is up, sometimes there can be some residual cortical vitreous that can be identified with the use of triamcinolone. Once that's all done, you can perform your panretinal photocoagulation. Remember not to forget the anterior retina, so either with the aid of scleral depression or later on in the case under air, you can get to that anterior retina to complete the PRP. And then again, I like to do an air fluid exchange at the end of the surgery to remove any residual vitreous hemorrhage, and then also with the air in the eye, I think that if there are any oozing blood vessels, a clot will form over those oozing blood vessels and hopefully minimize the degree of postoperative vitreous hemorrhage. One last step that I do like to do just to confirm that I've got good hemostasis is to go ahead and drop the intraocular pressure to about 10 millimeters of mercury. So oftentimes we're operating at 25 millimeters of mercury, which is higher than the pressure will be in the postoperative period, in the immediate and later postoperative period. And so I like to do a little bit of a stress test by lowering the intraocular pressure to about 10 millimeters of mercury, look for any oozing blood vessels, diathermize those if they're present, and then go ahead and do the air fluid exchange. This is a very beautifully done case, and a complete case. This is shown at a fast speed so that we could get through the entire case, but really a beautiful job done by Dr. Gonzalez, demonstrating all the different principles, all the different techniques for successfully treating diabetic tractional retinal detachment. So thank him. I want to thank him very much for sharing this case. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.